Okay, thank you. Good afternoon, doctors. Welcome you to this webinar on experience sharing program on managing PPH. Today we have our honorable speaker, Dr. Sanjay Shah with us. Welcome, sir. This
Yes, thank you.
program is brought by Hetero Healthcare. As you all know, Hetero Healthcare has got 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FTUs. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. We are pioneering in quality and innovation, and we have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's program, Experience Sharing Program on Managing PPH, we have got, as I said, Honorable Speaker Dr. Sanjay Shah with us. Dr. Sanjay Shah is consulting obstetrician and gynecologist, endoscopic surgeon, and IVF specialist. Sir has passed his MBBS and MD from GS Medical College and KM Hospital, practicing for our last 35 years at AMI Maternity and Surgical Hospital, Dahisar, Mumbai. Addressing infertility and vaginal hysterectomy, has been past president, Dahisar Medical Association. With this brief introduction, I welcome Dr. Sanjay Shah, and over to you, sir, with our next slides.
Yeah, thank you for kind introduction, Dr. Prashant. Here, postpartum and what best we can do to prevent a postpartum hemorrhage. This is the topic for today. Go for the next slide, please. So let us understand a postpartum hemorrhage. Of course, we need not to go in detail because most of the observation, whenever we deliver the patient or we means either by normal delivery, if it is a normal delivery, the loss of more than 500 ml blood, section, then the loss of more than 1 liter is called PPH. PPH is common and in women who are not at risk, because there are certain PPH where we can predict the risk factors, but there are certain will just have PPH without any notice. PPH is leading cause of maternal mortality in low economic countries and in the all maternal deaths globally. Yes, please. So the causes are divided, now maternal mortality, it is a leading cause of maternal mortality accounting for all maternal deaths. Maternal, that is MMR in developing countries.
Your voice is breaking, sir, in between.
Yes.
Your voice is breaking in between.
Is breaking?
Voice, yeah, in between.
Now you hear?
Yeah, now we can hear, but
yeah. Developing countries was 240 per live birth compared to 16 in countries. So maternal mortality ratio is MMR. In developed countries and developing countries, there is a vast difference. Global PPH incidence, 14 million women suffer from PPH. Incidence of PPH is reported as delivery and 6% after cesarean section. Now, PPH incidence is when India, 38% of maternal deaths are due to PPH. 20.7% of global deaths take place in India, and 2/3 India has an unexpectedly high maternal deaths per 1 lakh lives. Next slide, Prashant. Yeah, the etiology of postpartum hemorrhage, that's the causes of PPH, which are divided into 4 T's. One is a tone, which is an inability to continuous bleeding. Then a thrombin, that means it is a coagulopathy, failure of blood clotting. Then trauma, injury to birth canal, rupture uterus, inversion of the uterus, and even a lacerations. And when we talk about tissue, that is retention of placenta and clots and abdominal placentations. Dr. Prashant, next. So clinically, we all know PPH will give a shock depending on the amount of blood loss patient has and earlier what her hemoglobin or even a condition is, general condition. So normally it presents as an abdominal tenderness, circulatory collapse, increasing abdominal girth, loss of uterine contractions, maternal tachycardia, and excessive vaginal bleeding. You can divide into three parts, like there is a mild PPH, or there is a moderate PPH, or it's a severe PPH, depending on the blood loss and the patient's change in blood pressure and other symptoms. When it is a mild, that is a blood loss of about 1 to 1.5 liter, which is a common in 15 to 25% of patients. There is a slight fall in blood pressure and even a slight tachycardia, and patient symptom signs are weakness, sweating, and tachycardia. A moderate blood loss, that is 1.5 to 2 liter, will be having with 25 to 35% of patients, but there will be marked fall in blood pressure. Systolic will go up to 70 to 80. Patient will have restlessness because of hypoxia. She will look pale, and there will be decrease in urine output. In severe PPH, when the loss is more than 2 liter, these are the patients of 35 to 45%. There will be profound fall of blood pressure. Patient will have collapse. She will be gasping for the air hunger, and almost anuria. There will not be any urine output. Next slide, please. Now, diagnosing postpartum hemorrhage, it is like initial evaluation. We see when there is a patient is bleeding, we all know there will be rapid assessment of patient status, as well as the treatment will be started for that. So rapid awareness of patient status, presence of tachycardia and it's a hypotension, assessment of vital signs and blood loss. Now examination at the time of hemorrhage, assessment of the entire genital tract for lacerations, hematomas, or signs of uterine rupture. Manual examination for retained placental tissue. Assessment with bedside ultrasound to check if required, uterus is contracted or not, or any placental pieces are retained or not. And inversion also. Laboratory assessment will go with complete blood, hemoglobin, RBC count, and hematocrit. Then profile and coagulation profile studies, and assessment of the serum fibrinogen. Next slide, please. So approach towards postpartum hemorrhage. Basically, attempts should be made to identify the cause in women who are bleeding in parallel with resuscitation. So if there is a poor, which variety of drugs are available, right from argometrin, oxytocin, as well as a misoprostol group, and PGF2 alpha. Uterine massage is also advised. If it is a tear or trauma, then a good clinical, a good examination in operation theatre under anesthesia to see if there is any laceration like cervical tear or extension of the episiotomy, or sometime uterine rupture will require a repair for the tear. Then retained tissue is, you have to, if you are suspecting inversion, then you reposit the uterus under anesthesia. If you are suspecting uterine retained tissues in the uterine cavity, then you have to do something like manual removal of placenta or removal of the clots, as well as few placental pieces. Next slide, please. So now we come to a main topic, is we are talking about atonic PPH, and in that also specifically it's a prophylaxis we are talking. So rationale for the development of carbetocin in new heat-stable formulation. What is the purpose of this molecule? Age-old, we are using oxytocin for so many years, and ergot alkaloids, that is metharzine, should be kept in a refrigerator to avoid a degradation. So in normally, pitocin and metharzines are stored in a temperature below 10 degree. Heat-stable formulation of oxytocin is currently not available. Previous formulation of carbetocin should be stored between 2 to 8 degrees. Resource not always have cold chain transport and storage capacities. So now the new molecule is stable at room temperature, has shelf life of 24 months at 30 degree to 75% humidity, avoids need for is provided in a vial. Next slide, please. So now, as we enumerated use of various uterotonic agents, a time of administration sometimes that is recommended at the crowning of baby's head, or at the delivery of anterior shoulder, or at the end of the second stage of labor, that is placenta is already removed, expelled, or following the delivery of placenta. Prophylactic use is prevention of PPH. Active management of third stage of labor is best thing for the prophylaxis use. And therapeutic use, when there is already atonic PPH, then we are supposed to use as a therapeutic. Now, what are the various molecules available to us? Oxytocin, carbetocin, ergometrin. There is a combination of oxytocin with ergometrin, misoprostol, and I would add PGF2 alpha. Next, please. Now, let us more talk about carbetocin. Basically, carbetocin is a next generation drug for PPH management. I won't say management, it's a PPH prophylaxis. It's an oxytocin analog. Carbetocin was created by making several modifications to the oxytocin structure. By using that, it helps in prolong the half-life, reduces enzymatic degradation. Now, drug is synthetic, long-acting analog of oxytocin. Therapeutic indication is prevention of postpartum hemorrhage due to uterine atony and posology injection. Next slide, please. Next. Yeah. So, carbetocin, now the various trials were conducted. Specifically, famous trial is WHO champion trial. It was proved the carbetocin is non-inferior to oxytocin. So, the largest clinical prevention of PPH. Study design double-blind randomized trial of compare a age standard gold standard oxytocin drip with one single injection of carbetocin to compare investigational carbetocin to oxytocin in the prevention of PPH after vaginal birth. Patients were enrolled about 30,000 women across the 10 countries, including India. Primary outcome was the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents, the proportion of women with blood loss of at least 1000 ml. Yeah. So here is the study is showing blood loss additional uterotonic requirement was in 14.5%, and almost same proportion was required in oxygen group. Greater than 1000 ml was in 1.51%, and similarly 1.45% in the oxytocin group. Safety anticipated abnormal 0.9% in oxytocin. At least one serious abnormal event, 0.7% and 0.6%. The frequencies of the expected AEs did not differ significantly between the two groups. a safe molecule because we for so many years the frequency of blood loss of at least 500 ml or the use of additional uterotonic agent with carbetocin was proven to be non-inferior versus oxytocin. The use of to stop bleeding and adverse effects did not differ. So, carbetocin was non-inferior to oxytocin for the prevention of blood loss for at least 500 ml agents. Next one. Yeah, carbetocin for prevention age concluded that is a Cochrane review. For women who undergo cesarean section, carbetocin resulted in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is blood loss compared to metrin. That is the prevention of who has vaginal disease and is associated with significantly fewer adverse effect. Yes, next one. That's a Cochrane review. Now we talk about guidelines. The guidelines recognize benefits. So different gynecological obstetric bodies have recommended, like WHO has carbetocin is given guideline for PPH prophylaxis. Of course, you seen ergometrin, methyl ergometrin, oxytocin, and ergometrin. International bodies also have approved carbet and Foxy also. Yeah, Dr. Prashant.
Sir, now coming to your experience with carbetocin, how long you have been using
Yes.
carbetocin?
Yeah, I am using carbetocin now more than, yeah.
More than how many years?
It is safer
Your
choice
voice is
in
breaking. Your voice is breaking, sir. More than how many years?
2 years.
2 years. And sir, the route of administration you use is generally intramuscular or intravenous?
So your voice is break.
My voice is breaking.
Yes, now you tell me.
You generally prefer intramuscular route or intravenous route?
No, it's a one bolus of slow intravenous.
Slow
After the
intravenous.
delivery.
Okay. I think we've got some internet problem.
Oh.
You all can hear Bivas?
Yeah, Wi-Fi is going on.
Yeah, I don't know. Bivas, you can hear, sir?
Yes, sir. I can hear Dr. Sanjay Shah.
Hi, na? Okay.
Yes, sir.
You are in office or traveling?
No, I'm somewhere else. Bivas is in office.
Okay.
Sir, I'm in
Go ahead.
office, sir. I can hear you, sir. Dr. Sanjay, I can hear you, bro.
Okay.
You can hear us, no?
Yes, sir.
You can hear us, no?
Yes, sir. I can hear you, sir.
Okay, go ahead.
Yep.
Yeah, Prashant.
Yeah. Coming to this question, sir, what is patient profile where
Yes.
doctors can anticipate PPH?
Doctors can anticipate PPH, fetal as well as maternal. The common maternal causes is over-distended uterus,
Okay.
previous history of postpartum hemorrhage,
Uh-huh.
and if she is having a PIH, that and multiple pregnancies.
Okay.
Where
And
you
fetal causes?
Fetal causes, again, it will go as a oversized baby.
Twins like.
Yeah, twins like.
Twins may
Come.
yeah. And
Yes.
patients with fibroid are also likely to get PPH?
Yes, definitely. Definitely.
The next question is, can we use carbetocin in case of a retained placenta? Of course, after removal of placenta.
we can use in the primary use. What I would be doing in my practice is
Okay.
retained placenta would be diagnosed only after maybe half an hour or something. But by
That's
that time,
right.
I must have given the carbetocin as a
Ah, yeah.
prophylaxis. So definitely,
Okay.
it's not
Okay.
contraindicated.
Okay. In RH negative mother, can we use it?
Yes, definitely, yes.
Any interesting case, sir, you would like to tell us,
Sir,
especially the audience?
yeah, what is it?
Any interesting case you would like to share with the audience?
Yeah, interesting case means
About your
see, I would
experience.
say I have used in most of the my experience in using carbetocin in most of the
Okay.
cesareans we use, which are very few, I would say
Okay.
severe PIH or something, hypertension,
Okay.
maybe a contraindication, but otherwise, it is a better molecule than oxytocin because normally what we used to use earlier, anesthetists will use oxytocin as well as either a methargine, that is
That's
argometrin,
right.
or is a prostodine.
Yes.
So there were two drugs were used. Now, for last 2 years, most of the cesareans we use only one ampule of carbetocin, and that is the preventive measures. And most of the patients don't require any other molecules or injections as a top up.
Okay. So it suffices, like.
Yes.
Can a doctor use
Yeah.
carbetocin for
Next question.
prevention? Yeah. Can a doctor use carbetocin for prevention of PPH if oxytocin is used for labor induction?
It can be yes. Yeah,
It
it
can
can
be.
be used. They the same analog with a
Ah,
longer action, longer half life.
okay.
That is the difference between oxytocin and
And
carbetocin.
carbetocin.
So we should use carbetocin without any hesitation.
Hesitation. I mean, you generally prefer IV, but is there any place of IM administration of
I,
carbetocin?
actually, honestly speaking, I have not seen being used.
Okay, okay. Maybe at places where there is intra-IV facilities are not there in the interiors especially, or you
Yes,
don't
yes,
have paramedical help. Maybe IM,
definitely.
yes,
Then can
formulation.
be used.
Yeah, even interior PHCs, etc. We know how things happen.
Yeah, I understand. I understand.
Yeah,
A midwife delivering and can use, of course. There is no
exactly, exactly.
definitely.
Any adverse effect profiles or any side effects you have seen over these 2 years?
Actually, I have not seen any single side effect of
Okay,
because of carbetocin.
because of carbetocin. That's
Yes.
good. That's good. That's very reassuring.
Yeah.
All said and done, sir, textbook reference and our doctor's experience, they are two different things. And our participants will always like your experience. You know, it will give them a confidence.
No, in fact, it is a very good drug to use because pitocin we are supposed to keep on, I mean, oxytocin we are supposed to keep on giving in diluted form for a longer time because the
Correct, correct.
uterus is likely to go again to become atony after some
Yeah,
time.
yeah,
In
yeah.
case
And then there's a side effect of ADH, likely
or
side, probable.
so then it will be
Probable,
slowly
yeah.
again will be there.
Yeah,
While
correct,
carbetocin will have a longer half-life, a
correct.
longer action, and definitely it is a better.
Yes. If the patient is not responding adequately with carbetocin, which can happen sometimes, then what next?
Yeah, of course.
Yeah, whether you can repeat the dose or additional neutrotonics, how do you go ahead
Yeah, see,
about it?
normally it can be repeated, but I have not repeated because then it
Okay.
becomes like you are not exactly preventing PPH, but you are treating
Correct,
PPH.
correct,
So
correct,
if on
correct.
table or after normal delivery, when you find that you have given a bolus carbetocin and still
Huh,
patient is having a flabby uterus,
PPH. Huh,
or PPH, then the next line of drugs would be either you can use argometrin or you can use PGF2 alpha or you can use misoprostol. One of the things you should use. But
correct,
there's no need of using a pitocin then again.
correct,
Oxytocin
correct, correct. In
is not
fact, in
required.
such cases,
Yes.
it would be treated as a treatment of PPH more than prophylaxis.
Exactly. Very clear. Very clear. And one most
Yes, yes,
important thing in carbetocin is that only
yes.
new in the but it is not for the treatment of PPH, it is
Treatment,
for the
correct, correct,
prevention
correct.
of PPH. That
Absolutely, absolutely. Prevention of PPH. I'll go to the next one.
I
What are
think
the advantages?
we just said that, like a single bolus injections, a longer
Correct.
half-life, and a better action.
That is correct. These are the advantage actually,
Yes.
and most importantly, cold chain may not be necessary as much as is for
Most
oxytocin.
important, most important. And
Yes.
another thing
Do
I will add is there are certain conditions where suppose you are using only oxytocin and
oh,
like asthma or somewhere, then you can't use prostodin, that is
prostaglandin.
PGF2
Yes,
alpha
correct,
naught.
correct,
So I
correct,
would
correct,
prefer
correct.
that if I use carbetocin, it is a better action so that I don't need any
Absolutely
other drugs afterwards.
correct, correct. Prostaglandins are contraindicated in those patients,
Exactly. Yeah.
and hypertension, etc. Methergine we don't give.
Correct.
Yes. Should carbetocin be kept? In fact, you have already answered this. As a reserve drug,
No,
or
no,
should
we
we
have
use
to
as a
use
first
the
line?
first line. First line.
Exactly, exactly.
Yes.
And what is the role of anesthetist in general vis-a-vis gynecologist in choosing a drug for prevention?
I think it's always the obstetrician who says to an anesthetist what is to be given during cesarean.
Okay, okay,
So only thing is, most of the anesthetists in my practice I have found now they have become more comfortable to that extent that I go to sometimes some different hospital to operate, and
correct.
the different anesthetist says, "Sir, you want carbetocin, like, or you want age-old thing, like."
Correct, correct. That's
So
the confidence of the drug, about
yes,
the drug. Yes,
yes.
correct. And so to conclude, your overall experience and take-home message for the audience,
Yeah, I think we
your
just
experience.
repeated. We can repeat again.
Yes,
Basically, it's a value for money molecule. It's a great advantage of prevent prophylaxis (PPH) prevention, which is a definitely dreaded clinical situation. And most important thing is it remains a longer half-life with longer action. So once the uterus is contracted, it doesn't become again flabby, and
correct,
considerably it is better used than IV oxytocin because there's a different some people use 10 units, some people use 20 units. Here we are sure one bolus of 100 microgram is adequate to prevent a PPH.
correct.
Yes.
Thank you so much, sir.
Thank
Thanks
you.
for your
Thank you, Dr.
time.
Prashant. Yeah, yeah.
Thanks, thanks. Thanks,
Yes.
marketing team, Hetero team. Thanks, all the audience who took time from the schedule and attended this.
Yes.
Thanks, marketing, yes, and Hetero and IT team of Hetero for conceptualizing, and sales team of Hetero. Thank you
Yes.
so much, and you can sign off, sir. You'll be
Thank you
having an
very much.
evening practice. Yes, thank you.
Yeah,
It
yeah.
was lovely. It was
Thank you
lovely.
very much. Nice talking.
एक ही बात है सर, आप केएम के हो, मैं जीएमसी का हूँ बस.
वो तो अच्छी बात है. That's the best combination. Because my morning walk friend is GMC.
Okay,
So
sir.
nice.
Thank you.
Thank you.
Thank you.
Nice. Thank you.
Thank you. Yes. We'll leave. Huh?
Right, sir. Bye bye.
Yeah. Bye.
Bye, sir. Thank you.
Yeah.
Thank you, Nagadevi. You can also,
Thank you.
close the meeting. Thank you.
Yeah, okay, Bhimas. Bye.
Bye bye.